You don't need to subscribe to the mailing list. You accept the agreement, and then you download, okay, the English version of the registered nurse exam preview. Later, you can download the practical nurse, the LPN, and you'll see that it's very similar. Okay, but you know what that they don't have is the level of management that has DRN. But a part of that in content is very similar. But they download this. And you will have this test. This test, okay, let me go to the beginning because I was working. Okay, this test, okay, no, the science is okay, has 147 questions, and is going to be similar to the test that you will have. I mean the proportion of traditional questions. I mean, multiple choice. You know what is multiple choice? You have 4 options and you choose one. Or Celedo that apply, you know the Celedo that apply. We already discussed, because I already discussed with the MRU people, that now you are sure that you are going to have partial credit. So you are going to be credited for what you know. But remember that you will be penalized. You have a microphone open for what you don't know. So if it is, you have a microphone open, trying to close your microphone. If you have A, B, sorry, C, D, E, F, and this is okay, you have 1 point. This is okay, another point. Okay, another point. But if this is, and you mark this, okay, you mark this, you mark this, you mark this, and you mark this. But this is no okay, it is wrong. This is going to cancel this okay. So recommendation, trying to answer in the multiple choice those that you are, secure, you're sure of the answer, no? And those that you are very dubious, okay, leave that in blank. Okay. Okay, so this is something that I wanted to comment about these cellular apply. Okay. And you will have the new type of questions, okay, the new generation that are going to place you in a clinical like scenario, like in front of a client, and you need to take decisions based in this clinical scenario. Decisions like calling the doctor, decisions like giving oxygen or giving fluids, or anticipating a medication or a test, that are going to be, like I said before, between 15 to 18% of your test, the new generation. Guys, give me feedback. Have you been able to reach this page? Yes or not?
No, Professor.
No. And why aren't you in a computer?
Yeah.
Okay.
No,
So
now I can't able it. Yeah, before, but I never did it before. That's what I want to say.
okay, but now could you
Yes, I
reach
open.
the test?
Yes, I'm like the same page with you.
Oh, okay. This is that I wanted to be sure that you are in this page. So I really like to go over this test with you. Okay, probably we won't be able to finish that in 1 day, but in, I think, 2 days we can do it. I really want to go over the test with you because I found that it is a real NCLEX like test. Do you agree?
Yes, Professor.
Yes, Professor.
Okay, so let's start. Let's start with the first question. The first question say the charge nurse has received a change of shift report on the following clients in labor? So the first question that we have is an OB question. The charge nurse should ask a staff member to first see the client in the, so obviously it is, do I understand the question? It is a priority question. So we have four laboring clients, and we need to see one that is in problems. Okay, so we have a first stage of labor who has an oral temperature of 99.7. They give you the Fahrenheit and Celsius degrees, okay, whatever you are more used to do. So, what do you think about this temperature? I think that this temperature is normal. Do you agree? Yes. So obviously, because it is a normal temperature, we don't think that it is a case to see. Do you remember that the labor has four stages? One, two, three, and four. You need to know that because it's tested. And do you remember that the first stage is from the first pain, the first painful contraction, real contraction, not fake contraction, until from the first contraction until the client reaches 10 centimeters of dilation of the cervix. The second stage, when you reach 10 centimeters, is the stage in which you expose or give birth to the baby. Baby is born, okay? Born, the baby is born, so comes out. The third stage is when the placenta is born. And the fourth stage is a couple of hours of observation after giving birth, just in case mainly a bleeding presents, because bleeding is the most important case, and observation is the stage. Bleeding is the most important complication of labor, and for that reason deserve a special stage of observation, because most of those bleeding occurs immediately after the birth of the placenta. Remember that the first stage is too long, can last almost 12 to 24 hours. And for that reason is divided in three phases. The phase that is slow is called latent. The phase in which the woman start having more frequent and intense contraction is called the active phase. And then the most the strongest contractions and the most frequent contraction are in the transition, okay, uh, phase. We know that the active is when the woman is between 4 to 7 centimeters of dilation. So the latent is going to be from 0 to 3, and the transition is going to be from 8 to 10. And this is what we use to decide in which phase of the first stage is the woman laboring. Remember that the transitions when the contractions are the strongest and more frequent. And you need to remember that the in this stage, the contractions are going to be very frequent. One contraction every 2 to 3 minutes, which is nothing. And each contraction will last between 60 to 90 seconds. So this is the content to understand this question. So the temperature is okay. The other woman is also in the first stage, so is here in the first stage. And the contractions are happening every 30 seconds. The third is in the second stage, so is in this stage, and has an increased respiration. Have you heard that is recommended women that are in this transition in um, um, second stage of labor to have a hyperventilation to enhance the oxygenation of the baby and to improve the strength of the contraction, And there is a technique where we teach the client to do a respiration like the dogs when they are playing, when they are, tired or hot. That is the dog respiration. Okay, so this is something expected in this strong laboring, okay, phase, and should not should not be in the big concern. If you are exercising, this is going to be, for example, your respiration. You know that these are respiratory rate that we usually mention between 12 to 20 is at rest. At rest, labor is not is anything except rest, especially the second stage is a physical effort. Okay, so you need to understand that. And then the last second stage, so the second stage of labor, whose contractions are lasting 60 seconds. We said that the duration should be between 60 and 90. So it can be 60, 70, 80, or 90. Yes. And so 60 isn't the normality. So obviously, the answer of this question, the client that is not okay, is number two, because it is okay. This is okay. So it need to be number two. Why? Because the contractions are coming every half a minute. So 30 seconds is half a minute. And we said that the most frequent, that is acceptable, the frequency of the contraction is one every 2 minutes. So this client is having a very, rapid contraction one after other. Remember that when the uterus is contracting, the blood is not reaching the placenta. So the baby is not receiving oxygen. So this baby is at risk of dying because there is no rest between the contraction to oxygenate the baby. During the non-contraction, during the relaxation of the uterus, is when the baby receives the blood flow and the oxygenation. So probably this baby is going to be in a predicament, is going to be in with late decelerations, which is not good, or with a sustained bradycardia, or even dead. The other thing that can happen with these contractions so fast and frequent is that the uterus can, burst, can suffer a rupture of the muscle of the uterus. Other thing that you need to know about that it is an evident priority, this frequent contraction has a name and can be in your English. It's called like tachycardia, tachy, like tachycardia, systole. This is the name given when the uterus is contracting too fast, too frequent, like in this case, more frequent than 2 minutes, than one every 2 minutes, called tachysystole, and have been tested this name in English. So what is has been tested, they give you the tachysystole, what this means. Okay, and it is a very frequent or rapid contractions one after the other, which are not good because can kill the baby and can break the uterus. Okay, remember that generally this excessive contraction or tachysystole is because the patient is receiving oxytocin. Okay, oxytocin. Okay, oxytocin. And the other way, oxytocin. And that oxytocin should be stopped, okay? Um, when the contraction works every 2 to 3 minutes. So probably somebody forgot to monitor this client, and for that reason, those contractions are so frequent. So I think that we learned a lot of stuff from this question. Is okay? Can we advance to the other? If you have a question, interrupt me. Next question. The nurse is observing a staff member caring for a client who has chickenpox. So now we go to infectious diseases. Chickenpox, the other name is varicella. What we know about this disease? Well, it's a viral disease. Uh, is a disease that has a vaccine, shouldn't be happening, and is a disease characterized by a rash that has vesicles, pustules, and crust or scabs. And meanwhile, the person is having lesions that have not been scabbed, that have to still have no scab or crust, then the person is infectious. And the breath, the air that the person is expelling is infectious. The virus is in the breath. And also the virus is present in the skin lesions. So the chickenpox requires isolation because it's highly contagious and requires isolation for the air, so it's airborne, airborne, and requires isolation for the skin lesions, so it's contact. Your microphone is open again. Okay, close your microphone. Yes. So requires this isolation in airborne and contact precautions. So once that we make this mental review of what is a varicella chickenpox, what says the question? Which of the following action by the staff member would require the nurse to intervene? So what means to intervene? That this staff member is doing something wrong. So we are going to, it's a negative question. We are going to, to look for a mistake, something wrong. So let's see, placing the client in a private room with monitor negative air pressure. This is part of urban, so it is correct. We can rule out this option. Placing a box of disposable face shields outside the client's room. Okay, we need to understand the meaning of the word. They are saying face shield. So we need to know what is a face shield. If you've never seen a face shield, you need to Google that. It is a plastic barrier. It's a personal protective equipment. It's like a plastic barrier that is fixed in the head of the person and is transparent. So the eyes, the nose, and the mouth that are our portal of the mucosa, no, that we have our portal of entry, no. So it is your hair is here, okay, is here, and it is covering you, no, it is covering you. It is a face shield, okay. Um, placing an alcohol-based hand rub in the client's room for hand hygiene. Tell me something, a person with chickenpox in airborne and contact precaution, can the nurse or any other person replace hand washing, soap and water hand washing with alcohol-based hand rub? Yes or not? Can be replaced? Yes or not? What is your opinion?
No.
No.
Yes.
No,
No.
your opinion is not, but somebody said yes. So interesting. Okay. Okay, I want to um, secure this concept in you. The Center for Disease Control, that is the authority that we have in infectious diseases, okay, and the one that your NCLEX is following, says we have made enough research, clinical trials, and we know that we can yes, replace. We can replace hand washing, soap and water, hand washing with alcohol-based hand rub, except when the disease is transmitted by spores, because the spores is a form of survival of bacteria, some bacteria that is resistant to the alcohol and the disinfectants. So spores cannot be killed by alcohol. So in case that the patient has a disease produced by sports, the alcohol is not working. The disease that or the agent, the infectious agent that has a spore with and found with the highest frequency in the hospital is the Clostridium difficile, which is very common. So if the client is treated for Clostridium difficile or has been diagnosed for Clostridium difficile, you can't use alcohol based on hand rub or sanitizer instead of soap and water. You need to wash your hand with soap and water, and you need to clean everything with soap and water. The other situation in which the CDC insists that you should not be using, obviously, alcohol-based hand rub if your hands are visibly soiled. Of course, you have the hands soiled with, I don't know, blood, uh, dirt, caca, vomits, or whatever. You are not going to be spreading this in your hands, like, with alcohol. You need to wash your hands with soap and water. Okay. Of course, after you go to the bathroom, also you should be doing that. Okay. And a part of these two very clear, okay, um, contraindications of using alcohol-based alcohol-based hand sanitizer? The answer in this scenario is yes, because the alcohol is effective for most of the bacteria that have no spores, most of the viruses, okay, and it is okay. So I want that for test purposes and align with the Council Center for Disease Control, this is correct. We can, yes, okay, use alcohol-based hand sanitizer for the hand hygiene of a client with chickenpox. And it is important because, okay, we could fail this question if we have a misunderstanding of this rule. If you don't understand what I'm saying, please stop me and ask me to repeat or contradict me or whatever, okay? Placing a surgical mask. Surgical mask is the same mask that surgeons use when they are doing surgery. It's a regular surgical mask. The blue one, the one that you know that is so simple, is not the N95, is not the particulate respirator, no? Uh, Placing a surgical mask on the client face, if the client need to be transported out of the client's room. Is this correct or is incorrect?
Is correct.
Yes, correct.
Is correct. Is correct. If we need to enter to this airborne room, we, nurses, doctors, CNAs, housekeepers, visitors, need to be wearing a N95, a respirator, which is a different and more strict mask than the regular surgical mask. But if it is the client with tuberculosis, the client with chickenpox, the client with measles, that must go out the room for any procedure, whatever, the client is done with a regular surgical mask. So it is correct. So then, based in this defense that I made of the other options, the answer must be two. So in which situation, who can tell me in which situation we use a face shield?
When there's splash.
When there
When it's a
is
splash.
a splash. That's it. And there is nothing here in this question that say that the nurses or as a routine is there is going to be a splash for all the intervention with this client. So there is no reason of placing outside the room. Outside the room, we can place a little cart with N95, gowns, and gloves. Because remember, this is also contact. Yes. So we need that outside the room to have available N95s, gowns, and gloves, but no face shields. The face shield is going to be specifically look Okay, if we are doing something that implies a splash, but there is nothing here that says that it is splash. So that's why there is no need of placing a box, a complete box, okay, of facials outside, because we are not expecting a splash, because here in any moment they mention a procedure that implies a splash. Good. So look at this. This question is English question. This is a question that can be in your English. Okay, this is a question that can be in your English. If you think that those questions that are disclosed here cannot be in your English, you are wrong. Of course, English test bank has 10 of thousands questions. So the chance of having the same question is difficult, but you can have this question in your English. This is an English style question where they are exploring your knowledge of infection control. The nurse is caring for a client who reports feeling faint and is experiencing the cardiac rhythm show in the EKG or ECG strip below. So now they show you in the English the strip. So what we see here is P and QRS and T. Yes, we see that. So we have P wave. So it is a sinus rhythm. But what we notice, they are very separated. So we can 1, 2, 3, 4, 5, 6, 7, and 8 boxes separating. Notice that we don't have um, any other resource here. Okay, in this case, we are lucky because we have the marks. Okay, the marks. Okay, that could allow us to count how many QRS are between. Okay, uh, 3 marks. Okay, and we have 4, and you multiply that 10, it is 40. Okay, so you have different way of knowing, okay, the heart rate. uh you can memorize that we should have between 3 to 5, okay, big boxes between the QRS. More than 5 boxes, it's a bradycardia. Less than 3 boxes is a tachycardia. So quickly you can know if it is a tachycardia bradycardia. But then in this case, because you have these marks that are seen here that usually are not present in the English, but just in case, because they need to use graphics that not necessarily have those marks. Um, you can, in this case, you can calculate that the heart rate is 40 per minute. A heart rate of 40 per minute can explain, well, the client is faint. Tell me something. If you have a client that enters the emergency department walking with a wound in the head, because has been fainting recurrently, has been fainting a lot, and uh, fell and has a head trauma, a wound, bleeding wound in the head. What is the first that you do with this client that is entering? And you are the nurse here. You are the nurse here. Okay, you are the nurse here. The client is entering with that, and you know that the client has a heart rate. Is set in the question, have a heart rate of 40. Okay, so what is the first that you do with this client? What is the first that you do with this client in an ER situation?
Assess for more.
See the
Uh,
patient.
The answer is that, guys. See the patient. Okay, that's why I draw the chair there. See the patient. You don't want the patient falling again. Then, after the patient is sitting and the patient is safe, remember, safety is important. Safety. Okay, after the patient is sitting, or if there is a bed, okay, on bed, in bed, okay, the patient is in bed, okay. Now the patient is safe, okay, because okay, the patient is conscious, but the problem is that it's very low frequency. When he's standing, You remember that the heart must pump the blood. The heart must pump the blood, okay, to the brain against gravity. Gravity is pulling down, so it's going to be more difficult for the heart having this bradycardia, irrigating the brain with blood and oxygen in this standing position than sitting or recumbent. Okay, so please have that. It is an English question, and you got that good. Congratulations. Uh, uh, the answer was okay. C declined. C declined the first share that you've found. Okay, this is a scenario question in a scenario. Okay, so so that's it. What we have here is a bradycardia, and we know that the organ that is going to be suffering the first of this bradycardia is the brain, because when a person is in the orthostatic position, so upright, the brain is in the highest position, and is going to be the organ that is receiving the least amount of blood and oxygen, which should be the contrary, brain is receiving most of this blood. So this is what we have here, a bradycardia. So it is a select that apply question, and they are asking appropriate, okay, intervention. Okay, do you administer a beta blocker to this client?
No.
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 Okay, unless you hate the client, and you should not be doing that even if you hate the client. Okay, so please no. But it is possible to place a pacemaker, this pacing pacemaker through the skin. Have you heard if it is possible? The
I
silence,
don't know about that.
the silence tell me that you never heard that. Okay, please
It's about
incorporate this
that.
knowledge. Incorporate this knowledge. Yes, there is a type of pacemaker. Of course, it's transient. Okay, mute the microphone. It's transient. Okay, it's not permanent. In which the nurse can place two pads, two stickers in the chest connected to uh, cables and a device that is going to be pacing, is going to be shocking the heart. It is not defibrillation. It's not. I'm not talking about defibrillation. Okay, it's not defib. Okay, it is not cardioversion. It's a pacemaker. A pacemaker. So the client is conscious and doesn't need to be sedated. But then through an electrical stimulus, this transcutaneous pacemaker can keep the heart beating faster. Meanwhile, the doctor can get a vein that is a procedure a little more complex, introduce the wire, cable, or lead inside the heart, and then open a pocket in the skin, and then place a permanent pacemaker under the skin and closes the skin. So notice that it is a transient, it's a meanwhile, okay, solution of bradycardia. It's called transcutaneous pacing. Uh, Meanwhile, the patient is having this transcutaneous pacing, is a little uncomfortable because the patient feels a tolerable sensation of electricity in the skin, and a part of the heart is contracting because the electricity, the intermittent electricity. Also, the muscles of the chest are going to be contracting involuntarily. It is something similar to a treatment of the pain that we can use called TEMS, transcutaneous electrical nerve stimulation. It's something that we can tolerate. It's something that is something that we can hold the sensation of the electricity, and it is a transcutaneous pacing. So it is correct. It is yes. Okay, so just in case you have in a question in the future that the nurse can follow in the doctor's order or by standing protocol initiate start a transcutaneous pacing is okay. Nurses can put this. Nurses can put it. Okay, so something that we learn. Good. Instruct the client to perform the Valsalva maneuver. Remember, the Valsalva maneuver is increases the intra-abdominal and intrathoracic pressure, asking the patient to bear down. Like pushing, like when somebody is constipated, or somebody is lifting something heavy, or when somebody is having a baby, is bearing down. Valsalva maneuver. Do you recommend the client to do Valsalva maneuver?
No.
No.
No, because Valsalva maneuver slows down the heart rate, and the heart rate is slow enough. So the Valsalva maneuver is using the tachycardia as an attempt to slowing down a tachycardia, but never a bradycardia. The Valsalva maneuver slows down the heart rate. So no. Begin chest compression. Does this client need chest compression?
No.
No, no. Chest compression, there is zero pulse, no pulse at all. In bradycardia, we don't initiate chest compression. Okay, so if there is a cardiac arrest, the client has a zero pulse, we initiate chest compression. Within the bradycardia, the client can faint, can pass out, can pass out, but then once is horizontal, recovers consciousness. Okay, so that's why the first to do is to put the patient as low, the brain of the patient as low as possible, without Trendelenburg, not Trendelenburg. Okay, but we make the patient recumbent, so no need of chest compression. Okay, let's see. Angina is the same as chest pain. It's pertinent to ask to assess the client for chest pain in this condition?
Yes.
Yes,
Yes.
absolutely. Yes, absolutely. Yes. For many reasons. First, maybe this bradycardia because the patient is having ischemia in the heart, is having a heart attack that can present in some cases with bradycardia and AV block. And second, even without having ischemia, this low frequency could be providing too little blood to the myocardium, producing angina. And because this assessment is not going to be harmful and is going to provide an interesting information, I think it is pertinent to do this assessment. So that's it. Suppose that we mark begin chest compression. So now this wrong answer will annulate this point. So instead of having 2 points, we have only 1 point. That's why when you have doubts, it's better to leave that blank in the new Nclex. If you have questions, stop me, but then I'm going to move to gain time. Let's see this question. The nurse is planning care for a client with moderate Alzheimer's disease. In English, they classify Alzheimer's in mild, moderate, which is the longest and the most common that you're going to see, and advanced or late. The advanced or late is a patient that is not talking, is a patient that is not moving, and is a patient that is having PEG tube for being fed. So practically is a vegetable. Early is something that is not going to be tested because there is a lot of people with early Alzheimer's and they are still functional, are driving, are doing whatever, no? So it's not more common. So the majority of the clients are going to be in this moderate Alzheimer's condition in which the patient starts becoming a safety issue, tends to wonder, is going to forget basic stuff like, for example, families and relatives, so they don't recognize them, are going to forget basic stuff like how to self-care, and are going to be needing guidance and etc., and can have those outbursts of anger or 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 fear, so emotion, uh, because they become emotionally unstable, etc., etc. Okay, so Alzheimer's. Okay, the question is, which of the following interventions should the nurse include in the client's plan of care. So they are asking for one intervention that is okay. So included, should be included. So we have encouraged the client to reminisce about happy memories. Uh, what you know about that? Obviously, the common sense tell me that reminiscence is remembering and enjoying those memories. No, uh, 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 if you reminisces okay about happy memory, I think that should be good. No, so I like this option. They say that for all people, this is good. So, for example, sitting with the old person to browse, a pictures album, okay, and to remember good moments is good. To have non people visiting is very good. To make them gather, so several people of the same background, the same age or similar age, same language, to gather, to enjoy together, to music of their times, to enjoy movies of their time, or simply to talk. This is what they referred about reminiscence. Okay, um, and they say that this slow down, doesn't cure, but it slows down the advance of the disease, the loss of memory, etc., and keep the mood elevated, etc. So the person is happier. So until now, by instinct, we like the first one. Let's see, but we need to read the others because maybe if there is another that is better. Confrontation, decline when inappropriate or agitated behaviors occurs. So when a client with Alzheimer's start misbehaving, start becoming aggressive because somebody changed the TV, channel. What you do, you scold and confront the client that it should not be done, or you take the client to another place and offer the client an ice cream or a snack. So this is what we discussed, that this is the trick that we use to deviate dysfunctional behaviors to a more functional behavior. Remember that we are using in Alzheimer in our benefit when we manage those clients, and also in the benefit of the client. No, we are using the fact that they forget soon. So if the client is upset with you, just go out, be around for 5, 10, 15 minutes and come back. And then when you come back, you find a different person, a person that don't remember, that doesn't remember the conflict that you had before. So is confrontation good? No. This is confrontation for whom? Confrontation is for antisocial personality disorder, that frequently they want to take control over you and you need to confront. Maniac patient, frequently because you are so grandiose, they they want to take control of everything, and sometimes you need to confront them. The bipolar, sorry, the borderline, sorry. The borderline sometimes need to be confronted. So when there is a a functional disease, not an organic disease like Alzheimer's, that can be reoriented and can learn, okay, and can recognize the authority. Sometimes you need to confront. So confrontation is therapeutic in those cases. But a patient with an organic disease like Alzheimer's, that in which they are unable to learn, they are unable to remember, this confrontation is going to produce more agitation, more conflict, and is not the best intervention. We discussed that in the last class, no? Yes. Administer to the client the cholinesterase inhibitor to reverse the course of the Alzheimer's disease. So this word reverse means that the disease it has cure, but at least can be reverted. And it is not true. Sadly, we don't have yet, and probably we won't have, okay, a medication that can regrow the brain. Maybe in the future there will be a medication to prevent the damage of the brain that happens in Alzheimer's disease, but never to reverse, to replace the brain. Okay, because it is impossible. So this word automatically should disqualify this option. The purpose of the medication given in Alzheimer's disease is to make the patient a little better, especially to make the patient easier to reorient, to manage, and maybe to slow down the advance of the disease. But you never could give this a false assurance that the disease can be reversed. You need to know that the medication used in Alzheimer's disease are this family of medication mainly. Okay, so those are medication that are cholinesterase inhibitor. Cholinesterase is the enzyme that destroys the acetylcholine. And the theory is that there is a deficiency of acetylcholine in the brain, in certain areas of the brain, and increasing the concentration of acetylcholine could the patient present a better, memory, a better reasoning, etc. Okay, um, um, that's it. So this word disqualify this option. Provide the client with information about activity choices in the morning so the client can make plans for all the day, okay, for the afternoon and for the night. It makes sense. It makes sense to give information to somebody that don't have memory, information in the morning to know what to
No.
do in the night. Doesn't make
No.
sense. Doesn't make sense.
No.
Okay, at all. And remember, the choices in plural is not good for us, all people. I commented that to you. And you need to limit, okay, the choices, and to be a step-by-step guidance in the moment that the activity is going to be done. Because of course, if you tell me something now, probably I'll forget that later. So, okay, so the best answer is to encourage the reminiscence, because it's accepted, is good for all people. That's it. So do you notice that those questions are mainly straightforward? You know or you don't know. That's it. And this is a type of question in English, okay, straightforward. The nurse is teaching a client how to ambulate using crutches. Okay, crutches. We need to master the most important aspect of the cane and the crutches because it's tested. Okay, and very basic, very basic. Which of the following information should the nurse include? So we are going to find the correct answer. Uh, remember very briefly, that the crutches are used when there is a problem in one leg or two legs, no? So there is a problem in one leg or two legs that cannot support the weight. And remember that in that case, the weight is going to be, supported. What this leg cannot be doing is going to be helped, the support of the weight, okay, with the upper extremities. So the upper extremities are going to help in this. And don't forget that the crutches uh, should not be uh, touching the armpit, the axilla, because there are some nerves that can be damaged by the crutches. Okay, and remember that these crutches should be in a position. Okay, should be in a position that the horizontal bar, the horizontal grab bar of the crutches should be at a height that allows the elbow to be flexed, in an angle of 30 degrees, 30 degrees in relation with the crutches, okay, 30 degrees. And remember that the tip of the crutches should be rubber tipped and should be making a tripod. Tripod is when if they are, the feet, then the crutches are going to be making like a triangle, okay? Where the tip of the crutches, this tip, okay, of the crutches are going to be a little forward and a little lateral. To be more precise, 6 inches lateral, 6 inches forward, okay? Uh, the center of the 2 feet or the feet, okay, the center of gravity of the body. This is the most important about crutches. Yes, it's true there are complex details about different type of march, etc. I personally don't think it is important. This is the beyond the scope of nursing. It belongs more to the scope of the physical therapist. But nurses need to supervise the client is safe, and this tripod position is safety because prevent falls and should be assured that is not harming the axillary plexus, the nerves that are in the armpit. And the nurse can regulate, because those are adjustable crutches, the height of the crutches on to make it comfortable and safe for the client. So once we make this review of crutches, let's see what the questions say. Use your hands and arms to support your body weight. Yes, okay, it is. If you use your hands to grab, okay, here is because you are going to be using your arms and hands to help support the body weight, because the legs that are the usual which supports this body weight are having problem. Wear slippers, okay. So let me erase this line because I don't know why I draw these lines. Okay, it is okay. This is okay. Where sleepers? Sleepers, are not safe. Sleepers, okay, are easy to get loose, and you can trip and fall because it's slipper. You should be wearing, okay, safe shoes or anti-skid, anti-slid, okay, footwear. So slippers is not good to be used with crutches. Maintain the crutches 12-inch, 30 centimeters in front of your feet while standing. This is contradicting. This is contradicting what we said should be placed the tip. They say that you should put the crutches here in front of your feet at a distance of 12 inches. 12 inches. So it is not a tripod position. So it is wrong. Definitively, it is wrong. So we discard this option. Adjust the hand grips, okay, those horizontal bars that you are grabbing the hand grips of the crutches so that the elbows are fully extended. No, elbow must be slightly flexed in an angle of 30 degrees, not fully extended. So it is wrong. So obviously the right answer is the first one. The nurse has taught a client with multiple sclerosis. Now a question about multiple sclerosis. We jump to neuro. Multiple sclerosis, an autoimmune disease of unknown etiology, um, is a chronic condition, progressive, has no cure, has palliative treatment, symptomatic treatment, and because it's an autoimmune disease, the treatment is mainly immune suppressors. No, immune suppressors. Remember that the disease produces a bout or episode of destruction of the myelin sheath in the neurons of the central nervous system and the peripheral nervous system. And those bout of demyelinization as a consequence of autoimmune activity of the immune system. Have exacerbation triggers can exacerbate a bout of demyelinization, and then the treatment or the time can partially, not totally, revert the damage. So there is an improvement. ¿Qué pasó? Okay, guys, are you seeing the screen? No. ¿Qué es esto? Somebody.
Yes, Professor.
Yes, Professor.
Well, but
Yes.
somebody is introducing. Okay. So you see the screen. You're seeing the screen. Okay. Okay. If you
No.
no,
Not now.
not now. Okay.
No.
No, because you cannot see that because somebody, share his or her screen. Now you should be seeing the screen. Yes. Yes or not?
Yes.
Yes. Okay. Okay. Somebody try to sabotage our class, but we are invincibles. Okay. ¿Qué estábamos diciendo? So multiple sclerosis, have an idea, no? Is a chronic, irreversible disease, autoimmune, but have periods of exacerbation, period of remission. When there is remission, the previous lesions can improve but never return to normality. Okay, more or less. Can affect practically everything. Brain, cranial nerves, vision, bladder, uh, motor, motor function, muscles, sensations, anything can be affected by multiple sclerosis, all the nervous system, okay? So let's see the question. Which of the following statements by the client, so the client saying stuff, indicate a correct understanding of the teaching? Okay, so we are going to look for the correct statement. Yeah. The options are: I will complete all my household chores in the morning when I am well rested. So the first that we should see in this option is the absolute all. When we see those absolutes, all, never, always, etc., we become a little suspicious. Not necessarily, maybe it's correct, but but we becomes a little, uncomfortable with these absolutes. And then what is said here, that you are going to do everything in the morning. So if you need to, qué sé yo, wash your cloth and dry your cloth and fold your cloth and clean the house and take the children to the school and and do the food or the lunch and the dinner and everything to do compacted in the morning because you wake up well rested in the morning. This is stressful. Doing that is stressful because you are running short of time if you try to do everything in the morning. And stress and overworking is one of the triggers of those bout or those exacerbations of those non uh, uh, just causes of worsening of the disease. Stress is one, heat is another, or changes of temperature, violent changes of temperature, and infections is another, like a flu, etc. Those are the most common. But I know that anchors insist a lot on stress as a trigger, so I think that it is not good. The person should spread, okay, along the day, the activities that need to be carried out to decrease the stress. There is one disease, is also studies in neurology, in which we recommend not all, but at least the physically strongest activities in the morning because the client is stronger in the morning. What is that?
Myasthenia gravis.
Myasthenia gravis. That it can be confused because you don't have similar, okay, initials, but it's different. Okay, myasthenia gravis is different. Myasthenia gravis is also autoimmune, but it's nothing to do with the myelin. Has to do with the acetylcholine receptors and muscle strength. It's limited to muscle strength. So don't confuse myasthenia gravis with multiple sclerosis. Okay. So no, we don't do that. We don't agree that. I have learned how to massage my bladder to help empty my bladder completely. Okay, a neurogenic bladder, bladder is a bag, and this bag has a muscle, okay, in the walls, and this muscle, as all the muscle, need to be connected with the nervous system, because it's the nervous system the one that make this muscle contract, and when the muscle contract will squeeze the urine out. No, so you pee when your nervous system and the muscle of your bladder, okay, decide to contract, and then you emit your urine, you void. Okay, those clients have damage, okay, these nerve connections, so the bladder could not empty well, and then they can a paralysis in the bladder, a neurogenic bladder. And what they're saying here is that if the person massage, okay, the bladder can be massaged above the pubis, okay, this bone that we have here, when the bladder is tendon, can be massaged, okay, can be massaged, or push, okay. And by the way, this maneuver was described by a guy, last name Crede, okay, Crede maneuver, and it is okay. I heard that it is okay. That is a trick that a person with neurogenic bladder can do to help empty the bladder. So it is okay, and even has a name, Crede maneuver. Let's see the other one, because we need to see all the options before deciding which one we are going to mark. I will take a hot bath. No! Heat is one of the triggers of this disease. So having a hot shower, okay, is not good, okay, because can trigger, okay, down the condition. I should expect the blurred vision to resolve. Okay, this disease frequently produces optic neuritis. The optic nerve is the second cranial nerve, and basically is to see, because these nerves have a lot of myelin. Sometimes in the bouts and the exacerbations, okay, in the crisis of myasthenia gravis, they can have generally is one eye, not both eye, affected with an optic neuritis. And for that reason, the vision can decrease, can be blurred, or can be decreased. The visual fields can be affected. And as I said, it is a chronic disease that had periods of exacerbation, crisis, okay, and periods of remission. When the remission comes after a while, and or induced by the treatment, the patient can improve of the deficit that was present in the previous exacerbation of the disease, in the flares up of the disease, but never return totally to the normality. This also make me understand that this person have a false expectation that a problems in the optic nerve will resolve. Resolve, the concept of the word resolve is that it is totally solved, no? Resolve, that is gone. It's like a flu. If you survive the flu or the coronavirus, it resolves, no? But then this person having a false expectation that the deficit will resolve with the medication. So to choose between 4 and 2, I prefer 2. For that reason, I prefer 2. Okay, so it is another question. As you noticed, everything is content, no? To know the condition, and is what we studied. Okay, so now we have here what a case study. Each case study will have 6 questions, and mandatorily, your test must have three, 3 case studies, and each one with 6 questions. So 3 times 6 is 18. Is the minimum number of new generation questions that you will have in your test. Okay. You could have more case study if your test is advancing beyond 85 questions, because the minimum that you're going to have is going to be that. Even you can have case studies that are not graded, but graded, you can bet that you will have 3 case studies with each 6 questions each. Okay. So let's start. A nurse note. Okay, the nurse in the ER is caring for a 41-year-old male client. I think that some of you practiced this question with me previously, but let's do that again as we've never saw that. Okay. And first I have the nurse note. You have available everything, the nurse note, and then later you will have, let me see, I don't remember. You have, okay, diagnostic result. So you can click in nurse note in the test and then click in diagnostic result and you can see everything at once. Okay, you can see that everything at once, but this is not dynamic, it is a fix. So we need to get along a screen by a screen. So be patient. So the first is to see the nurse note, okay? And the nurse note says 11. Is the first interaction, the first source of information. Client reports nausea, loss of appetite, vomiting, fever, and constipation for the past 2 weeks, and abdominal pain rated 7/10 in the numerical scale. Client states the abdominal pain started after my 7-year-old child accidentally kicked me in the stomach. Client plays soccer with the child once a week. The vital signs of this first interaction is fever, because this is fever, has a fever, important fever. Pulse 92, which is near the top, which is expected with this fever. Respiration 22, a little high. Blood pressure is acceptable, a little high, but this is not the moment of being very too picky with the normal level of blood pressure to prevent long-term diseases. Now this is stable. This is hemodynamically stable, and the pulse oximetry is normal, so the patient has a good lungs. No significant past medical or surgical history, body mass index 32. So this client is obese, is a patient that is obese. Okay, obese is first degree. Drinks alcohol only during social occasions, so it's not very important. Usually 3 beverages when has a party, so it's okay. It's acceptable. So it's not pertinent. Smokes cigarettes during social occasions. So the same situation is not defined. So obviously, what we have here is an abdominal issue, because the symptoms are mainly abdominal, uh, abdominal, but with an infectious component, because there is fever, and pain is significant. 7 is a significant pain. It's a pain that that is moving to severe. What is interesting is that the client relates the pain with a abdominal trauma, with an abdominal trauma. Okay. The other elements are not very pertinent. So they say, let me erase what I wrote. They said in this first, because it is the first of 6 questions, they say something. They want us to highlight the findings that will require follow-up. So we need to have a follow-up of the abdominal symptoms, or the fever and the constipation. Yeah, and we need to have, okay, we can do that together. follow-up of the abdominal pain. We need to have a no a, a follow-up of the fact that the abdominal pain started with a trauma. The fact that they play soccer doesn't need follow-up. And we need to follow the battle sign, especially the fever. This is not the moment to follow the obesity, the drinking, etc. Okay, but all the battle signs need to be followed up, I think. Okay, so this is a type of question. So how is exactly graded this? No, but they don't require exactly, okay, everything highlighted, but you need at least to identify the most important aspects. So for each items, okay, they're going to give you some credit, something like this, okay. So they give importance to the symptom, they give importance to the pain, and the trauma and the vital signs. Okay. Very good. The person who did that. Okay. Now it comes the second question. The second question. The second question of the same scenario, the same need. For each assessment finding below, click to specify if the finding is consistent with the disease process of bowel obstruction, appendicitis, or rupture spleen. So what they are exploring here, those could be the differential diagnosis that this initial case should bring. That the patient have a bowel obstruction, appendicitis, or rupture spleen. And then let's see the symptoms that they are mentioning, okay, have to do with any of those three diagnoses. Remember that okay, that you can know because you can access the diagnostic result, and the diagnostic result tells you the client has an appendicitis. Okay, you can know that before reaching that because you can open this and you can open this in the test. But they are asking, okay, but they are differential diagnosis. Okay, differential diagnosis. Which appetite. The patient has loss of appetite. If you have bowel obstruction, do you what is okay? Let me explain what is a bowel obstruction. You have, you know, anatomy, a esophagus. You have a bag that is the stomach. Okay, the stomach, and then you have a long, a intestine, small intestine that ends in the large intestine, no? And the large intestine ends in the anus. No? Sometimes there is something that produces obstruction here. When there is obstruction here, the liquid that normally produces the intestine builds up here and cannot pass. And the liquid tends to accumulate here in the stomach, and even the patient can vomit the liquid. This is what happens in intestinal obstruction. This obstruction can be a tumor, can be a twisting of the intestinal loops, can be a hernia, can be an adherences, can be etc. Infarction of the intestine, etc. Those are is an obstruction of the flow or advance of the intestinal content to reach the anus. Okay, so okay, bowel obstruction, appendicitis. You know what it is. and rupture spleen. You know that you have an organ here, which is the spleen, and it is in the left side and is under the ribs, but a trauma here can produce a laceration, and the spleen is an organ heavily vascularized. So it basically is going to produce a lot of bleeding and pain. Okay, and pain because the rupture. Okay, so now we will review the three diagnoses. Okay, appetite. They're asking, do you expect, okay, of those symptoms that the patient has a lot of appetite to be seen in bowel obstruction? Yes, the bowel obstruction having all this, intestinal content that is even vomited produces a lot of appetite. Also in appendicitis, we studied, okay, that we have a lot of appetite. But in a ruptured spleen, which is something acute, is something that patient has trauma, the spleen is ruptured, produces pain and bleeding. There is no classically reference to loss of appetite because it's not the classical complaint of the client. I don't mark lots of appetite in rupture spleen because appetite is not affected in a rupture of a spleen. Pain level. Pain is intense in rupture spleen and is intense in appendicitis. Nevertheless, in bowel obstruction, not necessarily need to be present because you can have, for example, an ileus paralyticus behave like a bowel obstruction, and there is no pain at all. So I prefer not to mark pain for bowel obstruction. Bowel patterns, constipation. So you have constipation in the bowel obstruction, and you have constipation appendicitis, but not in spleen rupture. And in general, gastrointestinal symptoms, all those symptoms can be found in bowel obstruction and appendicitis, but not in ruptured spleen. So what is the most probable diagnosis? Appendicitis. I like to add here, if I were, writing this question, the fever, no? That fever that is basically found in appendicitis, not in bowel obstruction or ruptured spleen, So obviously the most probable diagnosis appendicitis, okay? The bowel obstruction is the next. The list is ruptured spleen. Do you understand how to deal with this question? Those questions give you partial credit. In those questions, the wrong answer in this type of question, where you can find this information I'm telling you, there in this page that I taught you how to go there, you can find there how they are going to be graded, those questions. In this case, in this type of question, okay, there is no plus minus. So a wrong answer, if I mark here, is not going to disqualify that. They are going to be giving me credit for the correct answers. No, it's not going to be a penalization in that cases. Okay, simply as that. It's a simple evaluation. So the next question about the same scenario, nothing has changed, is select the three complications the client is at risk of developing, considering the most probable diagnosis. Confirm if you go and check the, ¿cómo se llama? The diagnostic results, you can see that. What you suspect that is the more probable diagnosis is appendicitis. Anemia, no. Peritonitis, yes. Septic shock, yes, the peritonitis can evolve to septic shock, but they are asking three complications. Dysrhythmias is not typical in appendicitis. Cardiac arrest is not typical in appendicitis. So the best option could be hypovolemia. Why hypovolemia? Remember, the patient is vomiting. The patient is NPO, so the patient should need hydration. Yeah, and fever. There are increased losses, insensible losses. And even if the patient, is having inflammation, there a third space can be building up, so liquid can be shift from the intravascular to the abdominal cavity. Yes, So those are the reasons for which hypovolemia is compatible as a complication of a patient with appendicitis. That's why the patient with appendicitis, you put the patient NPO, but you anticipate that IV fluids need to be initiated. Fever, dehydrate, vomit, dehydrate, having being NPO, dehydrate, fever, I already said fever, okay. If you don't agree or you want, okay, explanation, talk to me. Okay, I'm going to be developing the question the way that I've been answering in the test to show how the test, okay, developed. Notice it is the highlighted was the first, this is the second, this is the third. Now we go to the fourth question. So there is a new item mentioned here in nurse note that she notified or he notified the doctors and was awaiting orders. So now they ask for each potential intervention, accepting that the client has an appendicitis. Click to specify whether the intervention is indicated or not indicated. Clear liquid diet is not indicated. Patient need to be NPO. Enema, not indicated. Enema is contraindicating appendicitis. Applying a hot pad to the abdomen to alleviate the pain is not indicated. In appendicitis, heat can accelerate perforation. It is covered when we study appendicitis. All these are covered. Okay, so it's a content that you should know. Enema, no. Heating pad, no. Deep palpation, no. Diet, no. Yeah, very good. So what they have here, abdominal girth measurement. Okay, there is nothing wrong in that, and you know that the distension, abdominal distension, is important to see if the disease is advancing, is improving, or complicating. And an abdominal computed tomography CT scan, okay, that could be using iodine. Okay, it's not contraindicated. Is yes, because the CT scan can help to identify the appendix. They say each row must have one response selected and the same. They evaluate in this case, yes, a wrong in this one, a wrong answer penalize a good answer. So this, and you necessarily need to answer, okay, all the options. So if you mark here that you give the client clear liquid diet, this is going to annul, is going to cancel this point, because obviously you're doing something very wrong. Okay, you need to be penalized. So now comes the ¿cuál es esta? La fifth question. No, fifth question. Okay. In the fifth question, you have new information. 12:30, client transported to X-ray for the CT scan. 15 minutes later, 20 gauge peripheral venous action device inserted and normal saline initiated. Everything is okay here. 2 hours, 1 hour, 15 minutes later, client reports sudden relief of abdominal pain. We know when we study appendicitis that this is suggesting that the appendicitis complicated with rupture, and the rupture disseminates the infection beyond the appendix. The vital signs are practically the same. The only thing that the blood pressure, the heart rate, the pulse, okay, increases a little. Primary care provider notified and ordered a new CT scan. Client transported to X-ray to do another CT scan. So with this new information that you could already see the diagnostic results at this level, you are going to answer these questions. Based on those findings, complete the following sentences. The nurse should insert, and then you need to open this window to see 3 options. And then it will be a priority for the nurse to request a prescription of an. You open this window and you select of the three options. And the nurse should prepare the client for surgery within, and you open this window, and then you see that. So let's see the first option. By the way, the diagnostic results is telling you the first CT scan that is appendicitis, acute gangrenous appendix with a calcified appendicolit. This is a calcifications of caca, calcified caca that can be inside the appendix. That it could be the cause of the appendicitis. And then the next CT scan, report the rupture of the appendicitis. Okay, so let's see what the three options. The first option, okay, the nurse should insert rectal tube, nasogastric tube, indwelling urethral catheter. There is no need of a urinary catheter. The patient has no obstruction of the urinary outflow and is not hemodynamically unstable as to need hourly urinary output. We avoid the use of Foley when it is not necessary because you know that it brings infection. A rectal tube is not indicated in those clients, okay? Rarely indicated rectal tube. So what is yes indicated nasogastric tube because it's good to decompress the abdomen, especially in presence of peritonitis that produce ileus paralyticus. And it is going to be a nasogastric tube connected to an intermittent suction. And this is going to be removing the gastric liquid, okay, from the stomach, preventing abdominal distension, improving the symptoms, and preventing aspiration, vomits, and aspiration. That's why a nasogastric tube is the proper tube to be inserted. The next question says it will be a priority, and then boldface the word priority for the nurse to request a prescription of analgesic, antipyretic, or anti-infective. So what is the priority? The pain, the fever, or the infection? Obviously, is the infection. The patient has a peritonitis, so the antibiotic is the priority. And the last says the nurse should prepare the client for surgery within, and notice that you have 6, 8, and 24 hours. So what I do here, I choose the sooner of the option that they give to me. Okay. Then comes, I think, is the last question. Yeah. Here, client transported to the OR for open appendectomy, and then 2 hours later comes back to the medical surgical unit. Okay, 11 hours after the beginning of the admission, okay, because admitted at 11, okay, says client performing coughing and deep breathing exercises every hour while awake within centispirometer. Good. Performing post-operative leg exercise every hour while awake. Nasogastric tube remove. Good. Drinking clear liquid. Good. Abdomen board-like. So the abdomen presents symptoms of peritonitis. It's board-like rigidity with diminished bowel sounds in all quadrants. Rebound tenderness present. So the patient, no matter that the origin has been solved, the patient is still having the peritonitis. It will take time with antibiotic to resolve. Okay, with this evaluation, then they ask us, which of the following finding would indicate that the client is progressing as expected, o sea, is improving, yeah? Cellular apply is consuming clear liquid diet, is a progression. Board-like abdomen, no, this is not progression. Rebound tenderness is not progression. This is peritonitis. Still, this needs to improve. Using the incentive spirometer is improving. Diminished bowel sound is not the expected. Should have normal bowel sound. It is, part of the problem. The irritation of the peritoneum produces these decreased bowel sounds. And performance of leg exercise is good, so it's as expected. So those are the 6 questions related with this clinical scenario. What do you think? What do you think about those questions? Do you think too difficult, or by the contrary, think is they are more logical, more easy?
They're more logical.
So,
Like,
this is my opinion. As far as I've been saying, I think if you decrease your level of anxiety and you accept these new style questions and you remember you need to dedicate a little more time for this type of question to think very well, okay? I think it's going to help you instead of being, against you. It's more practical, it's more hands-on. Okay, let's continue with the other questions. Remember that the majority are going to be traditional questions. Those are going to be the minority. The nurse has attended a staff education program about caring for clients who are receiving positive pressure mechanical ventilation. Okay. Positive pressure mechanical ventilation is a client that have an endotracheal tube and a machine is pushing air, okay, inside the lung of the client. That's it. This is what a positive pressure, okay, means. Okay. Which of the following statements by the nurse would indicate a correct understanding of the teaching that has been delivered to the nurse carrying patients intubated with a positive pressure mechanical ventilation? Let's see. Clients should avoid range of motion exercise until weaned from ventilation. Weaned from ventilation when they are, removed of the ventilator. So I don't agree. Meanwhile, a client, probably those clients are going to be sedated, are on bed, and they are sedated because they are in mechanical ventilation. We need to keep, okay, the joints and the muscles and the tendon as preserved as possible. So you need to be very careful of changing position of this client. The presence of a tube doesn't contraindicate changing position. And if the patient is sedated, okay, we need to do range of motion, okay, of all the joints to keep, because sometimes those clients are, intubated for 7-10 days, sometimes less, sometimes more. Okay, and if a person is 7 days sedated and without having range of motion, the joint, the ligaments, etc., are going to shrink, and then later the patient could not be able to move properly. So it is wrong. We must be doing range of motion while the patient is sedated in ventilation along all those days. Client may develop stress ulcers and GI bleeding. Yes, it is important. It is true. It is true. When you are in those ICU scenario, critically ill, intubated, etc., there is in the stomach the development of multiple ulcers, holes in the mucosa of the stomach that can produce bleeding, a lot of bleeding, are called stress ulcers, are described in patients in ICU, are described in patients with burns, okay? In the case of patient with burns are called the Cushing ulcers. The patient ICU, the curling ulcers. You don't need to learn those names. This is not going to be in English, but it's just to convince you that we have been knowing for a long time that stress, physiological stress and psychological stress can produce very rapidly developing deep ulcers in the stomach that can bleed a lot. That's why you'll see that doctors systematically, as a routine, when those clients enters in acute care, they ordered omeprazole or any proton inhibitor that are the most potent, no, in those clients to prevent those stress ulcers. This is true. So probably this is the answer. clients will be chemically paralyzed to improve oxygenation. No, it is something that is not necessary in mechanical ventilation. Clients can be paralyzed during surgery. You know, you need to be very aware of those medications that produce paralysis. I don't know if you heard about this nurse that like 3-4 years ago, by mistake in Tennessee, gave a client a paralyzing agent, thinking that was giving a sedative. Okay, so she was intended to give Versed, which is midazolam, and gave a bancorium, which is a paralyzing agent. And when a patient is paralyzed, the patient is conscious, so is awake, but cannot speak, cannot breathe, and cannot move. So it's horrible. It's horrible. And of course, the patient cannot breathe, can die. And this is what happened to to this nurse. The patient died. Okay, and was condemned. Okay, for for murdering. Okay, uh, so there is no need of paralysis. The
Professor,
yes,
I have a question.
sure.
Why, how is chemically paralyzing the patient? How would it improve oxygenation though?
No. Paralyzing into improve it is wrong. But I just wanted to to make you understand that when you paralyze the client is paralyzed, is not breathing. You
Okay,
know,
so that makes no sense at all.
so it's not at all. I just wanted to comment based in this experience that this nurse had, that those paralyzing agents are used only during surgery, uh, uh, under the continuous supervision of the anesthesiologist to facilitate the work of the surgeon. Those medications, the pancuronium, the curating, the tubocurating, and the succinyl line paralyze the person, but the person is totally awake. So also the anesthesiology need to put the patient to sleep, no? And need to be, of course, always intubated, connected to a ventilator. There is no, sometimes, rarely, for short period of time in ICU, patients that are ventilated, maybe the doctor wants to paralyze the client because the client is critically ill and the client could be fighting the ventilator. Understand that the ventilator will help the client to sleep, which is the most common form of ventilation, is the assisted ventilation. So the client is weak and has problems in the lungs. Okay, they intubate the client and the machine will help the client breathe. So the client will initiate the breathing the same way that you breathe. And then the machine will help the client pushing more air and more oxygen in the lung each time the client requests, okay, initiating the inspiration, the breathing. Uh, from time to time, the machine can force some respiration. Those details to the different type of ventilation are not necessarily NCLEX level. This is not entry level, this is a specialty. But sometimes the patient could fight the machine. And then when the machine tries to help introducing air, the patient starts coughing or opposes the air entering. And then the high pressure alarm goes off, and then there is no agreement between the patient and the machine. In those cases, the doctor could sedate the client and paralyze the client until the patient improves a little. That's the reason for which, okay, paralyzation could be used in extreme situation. but is the exception, is not the routine. So definitively, I don't agree with this option because it's not the usual intervention when patients receive a positive pressure mechanical ventilation, because this type of ventilation requires the client initiating the cycle of the ventilator, requesting through a beginning of the inspiration, so with the initial sucking action. That so definitively no, definitively no. But I just wanted to comment that. Client will experience diuresis and polyuria, not necessarily. Okay, so I think that the answer should be this. Should be this. Okay, the positive pressure ventilation decreases the blood return to the heart. So this venous return to the heart decreases, so the urinary output decreases instead of increasing. Let's see this question. So everybody know that pressure ulcers, stress ulcers is a complication of patient with ICU and assisted ventilation, and we know that. Next question. The charge nurse must transfer a female client from the medical surgical unit to the maternity unit to make a bed available. Okay, this kind of question is very common in NCLEX, but notice this variation. Usually, the question we have been practicing in the past says the nurse must make a open bed, most open bed for patients that are coming. Which patient you recommend to be discharged because it's stable. So going home. This is the usual that I've been used to practice. I don't know you, but it is the usual. But this question has a different. The patient is in medical surgical unit and is going to be a transfer to maternity. So the patient is not going home. The patient is going to be transferred to OB. So what is my understanding? The patient that could be transferred to OB to open a bed in med-surg should be a patient that an OB nurse can manage. So what I'm used to identify in the patient that is going to be transferred home to be discharged is the patient that is stable. The patient that has several days, the patient has, a condition that it can be managed at home. But now it's different. I need to identify a patient that can be well managed with competency in OB, because it's a patient that an OB nurse can manage. So you need to visualize the scenario, understand the question when you read the question. So you need to identify of these 4 clients, which one is the best to be managed by an OB nurse, a super specialized nurse, a nurse that has been working for 20 years in an OB gynecological area. So we have a 20 years old right mastectomy and a closed wound drainage system, has a Jackson Pratt. And is a young woman, relatively young, and have, surgery in one breast. 49 years old, diabetes mellitus, and has just begun receiving insulin. So what I have here, a medication that is not commonly used in OB, and a disease that is not the most common in OB, and a patient that especially is needing a lot of teaching, okay, which is not the area of competence of OB. So I doubt that it is a good patient to be sent to OB. The first one, I don't know, but the second, definitively, I say no. 56-year-old, hepatitis C. Why is hospitalized with hepatitis C? Because the hepatitis is decompensated. The hepatitis is active, so probably has inflammation in the liver, probably has jaundice, anorexia. Is a standard precaution. It's a bloodborne pathogen, no? But it's not the ideal infectious patient to be transferred to a service that has a healthy patient, because a pregnant woman, a pregnant woman, a pregnant woman, and a newborn are healthy, So transferring an infectious disease to an OB area, for me, doesn't make sense, because I know it is a standard precaution, but it's a bloodborne pathogen, and we don't want to transfer, a infectious disease to OB. And what is going to require this patient? Antiviral medication, antiviral medication, antiviral. So our antiviral medication, which are the modern treatment of hepatitis C, drugs of that OB nurses, master or no, well, I think that no. Guys, if you don't agree with me, if you want to introduce an element that I'm not seeing, help me, okay? Because I don't know the answer. Remember, those questions that have no answer key is like the NCLEX, that you never know which one is the answer key. You never know what is the right answer. But we need to start practicing question blind like this, where we need to try to find the best answer. And even we need to find the book, okay, the support of our decisions. Let's see the last 70 years old. This is an age that OB nurses are not very used to deal with, no? Has a fractured left tibia, and has an orthopedic external fixation. This is something that have pins, several pins, and a ring in each one of those pins, and a lot of bars sustaining this, and has an orthopedic care. I think that the OB nurses don't have any. When they see that, probably are going to faint, okay, because they are not used to see this, and they are going to be asking, "What is that? What is that?" Okay, okay. I don't think. I don't think. I don't. So, what do you think? I think that the only one that a OB nurse can manage is somebody with a wound in the chest in a Jackson practice, because they can do that. Wounds, they can do that with OB and C-sections and C-sections. And the Jackson practice, okay, it's something that could be in a C-section or any kind of this. I think that the best is the one that I suggest to transfer is one. What do you think? Do you agree? Yes or not?
Yeah, it sounds like the more
Yes.
stable patient.
Looks, but based in this and this defense that I made of the others client that doesn't look out like pertinent for OB, I think the best is number one. By ruling out the other options. Okay, so now you are going to have an idea how it's going to be NCLEX lab. Not the same question, but the type of questions. This is management. This is management, an important component of your NCLEX. Registered nurse need to know how to deal with that. The nurse has been made aware of the following client situation. The nurse should first assess the client with a classical question of prioritization. But by the way, most of the questions you will have are going to be prioritization. Let's see what is the patient that is worse. Heart failure who has a productive cough and is anxious. Regional enteritis. This is the other name of Crohn's disease, okay? Crohn's disease is the same as regional enteritis, who is reporting cramping, abdominal pain, and diarrhea. It is expected. It is not a priority. What is expected in a disease that is chronic, a Crohn's disease is a chronic disease, generally is not a priority. Doesn't mean that we ignore the pain and we ignore the diarrhea. But in this case, we are looking for somebody that is in the predicament. Okay, the first one I don't know. Let's see. Okay, the next, idiopathic thrombocytopenic purpura, ITP. I know this disease. It's an autoimmune disease. Abnormal immunity, abnormal antibodies target the platelets of the client, that generally is a young woman, as most of those autoimmune diseases, and produce a drop in the amount of platelets. So this client perfectly could have 50,000 and even less, okay, platelets in the blood. This client has petechiae in the trunk, on the trunk, and heavy menses. But this is expected. If you have low platelet, it is expected. So what is the bleeding that would be concerning in a patient with ITP? Brain bleeding. So if they say the patient have a terrible headache and has somnolence or lethargy and has paralysis one side of the body, or bleeding in the GI. They say the patient is vomiting blood, hematemesis, or the patient is pooing blood, okay, melena. But they don't describe that. They say heavy menses, okay? Menses generally is something that is not associated with life-threatening hemorrhages, and petechiae is expected. Remember that I don't remember if I've already covered with you laboratory test. I think that yes, but platelets are critical, are priority when they are less than 20,000. Because in this range, the patient could start bleeding spontaneously. When you have in your NCLEX or any test, or in the real life, a client with low platelet, but is not in this range of emergency, the only thing that you need to do is avoid trauma. Don't allow the patient fall, prohibit falling. Yes, contact sport, don't take aspirin, avoid intramuscular shots, take care with constipation and rectal bleeding, etc. So prevention of bleeding, bleeding precaution. Okay, okay, but not it's not an emergency. So, okay, you have the microphone open. Try to mute your microphone. So it doesn't look. They are discussing the case. Okay, obviously. Okay. Hey man, your microphone is open. Okay, we are with, with, okay. Chronic obstructive pulmonary disease. Generally, COPD, because the chronicity is a distractor, no? Who has dyspnea with exertion. Well, when exercising had dyspnea is expected, and is using the accessory muscle of the respiration to breathe. This is the compensation. We use the muscle, accessory muscle, when we have respiratory problem. When we are tired, we were, exercising, and we have that. So it is expected. So must be one. Why one? When you see a client that is anxious, the number one cause of anxiety is not testing or the bills, is hypoxemia. Because oxygen is the number one need in our hierarchy of needs. And frequently, the term anxious, restlessness, etc., is used to make you suspect hypoxia in a client that is at risk of hypoxia. The hypoxia in heart failure is related to a condition called pulmonary edema. Pulmonary edema, okay, really with left heart failure. And in the pulmonary edema, there is accumulation of fluids inside the alveoli and the bronchi, and this is going to trigger the cough, and the cough is productive. And if they can expel the production of the cough, is going to be pink and it's going to be frothy. Okay, it's going to be frothy. Okay, pink frothy sputum. which is no more than the liquid that is flooding the alveoli. So the client that you should see first, the client you should auscultate first, the client that you could assess first for ABC is the B of ABC, breathing, is number one, because it's a client that is possible could be having a pulmonary edema. The other clients need to be cared, could be attended, but are not the priority. The priority is this for ABCs. If you don't agree, talk to me, okay? The next question. The nurse and an CNA, unlicensed city personnel, are caring for assigned clients. Which of the following tasks would be appropriate for the nurse to assign the CNA? A question of delegation, which is also management, the most important component of your assisting a client with atrial fibrillation to have a shower. No, the client is going to be in a shower, taking a bath with an atrial fibrillation. Checking the ability of a client to swallow water after a transesophageal echocardiogram, TEE. This is an echocardiogram that is done with an endoscope, with an endoscopy. Okay, that by the way is needed to be done before to evaluate, okay, the atriums. So checking the ability to swallow water. After that, it is assessment. You need to assess the gag reflex, etc. So it's unacceptable. You cannot delegate assessment of the gag reflex and the capacity of swallowing to a client to a CNA, of a client to a CNA. Observing while a client with dysphagia begins a thickened liquid diet, it is the same. It is by strategy. This and this is the same. Is the same. So cannot be either one. Transporting a client with respiratory distress to X-ray for chest X-ray. So it's between 1 and 4. Okay. Do you see something wrong in the last one, in 4?
The patient is unstable.
They say that the patient has respiratory distress. Okay, so do you delegate a patient with respiratory distress to be moved away of you from where you are in the service to X-ray under the care of a CNA no.
No.
Remember that when the patient has respiratory distress, is X-ray the one that comes to the client. Remember, they are portable, okay, X-ray apparatus that allow to you portable chest X-ray. So no. So need to be 1. Do you agree that a client with atrial fibrillation can shower? Yes or not?
Yes.
Yes. Majority of patients with atrial fibrillation are driving, are can be teaching, can be doing a acceptable level of life. Most 98% of AFib are chronic. This is the most common dysrhythmia you are going to see in your practice. The big majority, the AFib is chronic, and the patient must live with this AFib the rest of his or her life, and can be a long life, So atrial fibrillation is not lethal, is something that can be stable. The patient can have normal heart rate and can have normal blood pressure and can have a normal life. It's not a contraindication to drive, it's not a contraindication to have a normal life. The only thing that the patient with chronic atrial fibrillation must be taking 2 tablets. 2 tablets. 1 tablet must be a medication to slow down the heart rate, what is called a chronotropic negative medication. Usually is a beta blocker like metoprolol, or could be a calcium channel blocker, diltiazem or verapamil. And the other medication must be an oral anticoagulant, because the risk, okay, that has the chronic atrial fibrillation is can accidentally send a clot to any part of the body, among them the brain, producing a stroke, but could be to other part, not only to the brain, can be to a leg, producing a gangrene of the leg, or could be to the intestine, producing intestinal infarction, etc. But the most common, because the carotids are just there at the exit of the aorta, is a clot going to the brain. That's why they are all time taking an anticoagulant together with the tablet of the chronotropic negative medication. So they can be taking warfarin, or they can be taking the new direct anticoagulant like dabigatran, apixaban, rivaroxaban, okay? Those new oral anticoagulants we have now that are safer and don't need monitorization of the INR. Okay, so it's a patient that can have a shower perfectly, no problem with that. Atrial fibrillation, 98, 99% are stable, are client totally stable. It's true. All the rules have exceptions. You can have an AFib, acute new onset, acute, not chronic, acute AFib or new onset AFib, in which the client could have a heart rate too fast because it's not yet taking this kind of medication that slow down the heart, and then the patient could be unstable, hemodynamically unstable. But is the exception of the rule, is not the rule. The 98% are stable, and you take that for your anchors. Atrial fibrillation is a stable dysrhythmia that only require 2 tablets. The nurse has taken a nutritional history from parents of clients. Okay, so now it is pediatrics, because if we're dealing with parents, it is a pediatric question. And is about the nutrition of children. So let's see. It will be a priority for the nurse to follow up. Remember that this term follow up means that something is not correct. Something needs to be assessed, fixed, intervene, etc., etc. So let's see what is wrong here. 5 months, less than half a year. 5 month client whose only source of nutrition is formula, 5 feedings per day. 5 feedings is every 4 every 4 hours while awake. Okay, every 4 hours. Okay, an infant is the word. An infant can be fed only with milk until 6 months. Okay, this milk can be human milk, I mean breast milk, or could be formula. And this dose is adequate because at 5 months the child should be consuming formula every 4 hours more or less. So I don't think it is a problem. 7-month-old client who eats several crackers as a finger food. 7 months he'll be consuming solid food apart of the milk, and it's okay. Crackers are okay. So I don't see a problem here. 9-month-old client whose typical daily diet includes 10 bottles of 2% milk, 1 cup of apple juice. They can have apple juice at that time, and 3 servings of infant cereal can have cereals. Okay. Do you notice something wrong here?
A lot.
A lot of milk first.
Much milk.
But worse than that, the guy is consuming 2% milk, and 2% milk is cow milk. It's not formula.
Cow milk.
and they cannot have cow milk before the 1 year of age. Cow milk has a lot of sodium and overloads the kidneys of the infants, producing serious problems. Cow milk can also produce problems in the intestine, in the mucosa of the intestine, because the osmolarity of the cow milk. Cow milk is not healthy for infants, so they should not consume any kind of cow milk or animal milk different from human milk or formula. So it is not healthy. And then after 1 year, they can have cow milk, but need to be whole, cannot be fat decrease, must be whole milk. This 2% is a no. So only with this detail, it is not good. But then a part of that comes too much milk. 10 bottles. So suppose that this is consuming they don't say how much, but at 9 months usually they say a whole bottle. So is 8 ounces. Okay, 80 ounces, okay, of milk per day. It is going to produce a malabsorption of iron, and the client will develop iron deficiency anemia, the milk anemia. Okay, but a part of that is absorbed, this kind of milk. 8 ounces is too much. They recommend now they no more of 24 ounces, but well, in not at this age, in ¿cómo se llama? In toddlers, no more than 24 ounces of milk. 80 ounces is too much. So definitively, this is a problem. No, this is a problem that need to be followed up. Let's see the last 1 year. We already have 1 year. Whose typical food include 4 breastfeeding. Yes. So is it still drinking breast milk? It's okay. It's okay.
We can't hear.
Professor, I can't hear you. Professor?